Good afternoon and welcome to this afternoon's Ashgrove TV. It's great to have you here. Now today we're talking about arthritis and arthritic pains, and I've got our chartered physiotherapist Pierre Bonneau in the studio with me. Pierre has been qualified for over 20 years, and in addition to working in our clinic, he runs a neuromuscular skeletal module, a physiotherapy degree at Northampton University. Welcome, Pierre.
Thank you, Jay.
Now, arthritis, what a subject really, isn't it? It's quite interesting. I think that people probably protect their joints maybe a little bit too much when they've had their diagnosis. A good or bad thing? Should they be moving?
Right, how long do we have on the topic?
We only have 30 minutes.
30 minutes. Yes, in a nutshell, yes. But movement is key in arthritis. And I think it's important to understand what it is more than anything else. The NICE guidelines suggest movement, strengthening, but we need to see arthritis as a big picture. And when you have your diagnosis, it can be a bit scary.
Yes.
Because it's painful.
Yes.
It can be, you can have some swollen joints. It's understandable that people are fearful of it and don't really want to do anything because they think they're doing more damage.
Yeah, I think that was the point really with that first almost introduction, that I think a lot of people are really reticent, aren't they, to exercise because they're going to be told you're going to wear that joint, you know, all this wear and tear and all these kind of subject matter around it. But do you think with the right sort of controlled movements and things, it's good for people to?
Yes. I think we need to maybe go back a bit to defining what arthritis is.
What is arthritis?
I mean, it's interesting because you look at certain old studies, you know, you see changes as young as in your early 20s.
Yeah.
So if you did an X-ray, you're likely to see some arthritic changes. But these are people with no pain, no symptoms, no issues. And often people start to worry about it when they start to have pain, you know. And again, as I said, it's understandable to be fearful. And there's this stigma, this wear and tear that everybody's told that you're going to wear off your joint and it's going to crumble or being really damaged, okay? When actually arthritis is a whole joint issue. You know, we're not just talking about cartilage. We're talking about, you know, ligament, muscle, tendons, all the structures play and work together. You know, and those are the things you can really address. And then actually you need to start as early as possible to move. So you're not going to damage anything. Yes, there will be certainly some candidates where it's so advanced that maybe they're candidates for more invasive options. But there's a huge amount of things that can be done way before that to support patients and for anyone to manage their arthritis. Even the word arthritis in itself is a bit scary when you hear it, okay? When it means inflammation of a joint. Yeah,
people do get very worried when they hear that word, don't they? And I've certainly known people that will stop an activity they're really enjoying, even though they'll verbalise that actually they feel good during, no pain as such, maybe low level, and then post they don't feel a great deal of pain. But when they hear that word, they kind of want to stop, which is it's quite alarming for people, isn't it? And I think it's interesting you mentioned like the NICE guidelines, because it would appear now that there seems to be a greater advocacy for keeping people active, or at least the right activity with it once the correct diagnosis is given.
Absolutely. I mean, the NICE guidelines, NICE stand for National Institute of Clinical Excellence.
Yes.
Okay.
Yeah.
So they provide a set of guidelines based on review of the literature, and the key aspect is movement. But this movement is about moving the joint, because we lose a bit of range of movement in arthritis. Managing the inflammation, but also making sure all the tissues become more resilient with load. Okay, and you said people stop doing the activity they love and they feel really good about it. It's actually maybe suddenly to start with, maybe modify this activity, but suddenly not drop it.
Yeah.
Okay, I've found that the more you stop or the less you do, the harder it is to go back to it. And your tissues we talked about at the beginning, I say it's a whole joint problems. We talk about ligament and muscles and tendons. All those tissues are there to support the joint. They're the one often who are no longer able to or resilient enough to take that load. Okay, and not doing anything will make that less resilient. And you get into this vicious spiral of not doing much. When you need to do something, then it hurts, therefore you do less.
Yes.
And then if you do less, you're less able to do more. And so on and so on. Before you know it, you quite decondition.
Exactly. So you see that deconditioning process, which is actually, you as a physiotherapist, that's the last thing you want to see with a patient, isn't it?
Indeed.
Somebody actually becoming weaker.
Absolutely.
Because it actually makes your job a little bit more difficult then, doesn't it? If they're, in that essence, I know you can build them up again, can't you? But they're
Absolutely.
better I mean, funny enough, we've had a question from Sarah. And it touches on, Sarah asks, thank you for the question, Sarah. Is it safe to exercise with arthritis? And we've touched on that, I know. But Sarah's sort of a little bit more specific. Is there a kind of movement that helps most? I know that's a little bit general. I guess what Sarah might be getting at is different types of loading. You know, would we be, depending on the severity of it, we would change that person's rehab exercises, yes?
Yeah. So in a nutshell, it is safe to exercise, but what is important is to understand where you're at when you present with this. So a patient comes to see me, I will need to assess that patient to know where they're at, how long they've had the problem. There's a whole assessment that goes behind all this, okay? And based on what the person can do, based on discussions, you know, how much they can run, they can walk, how they react, that sort of thing, we titrate and we personalize the exercise and the loading so that we gradually re-expose those tissues to load. So they become more and more resilient to a point then you can aim for whatever you would like to achieve to an extent, obviously. But so exercise in itself is good, but not every exercise will fit everyone. It needs to be individualized. My experience has been that I can't take a whole set of exercise and give it as a standard to people who have, let's say, arthritic knees, for example, or hip pain, okay? Depending on what they do, what they want to do, what they want to achieve, how they may react to those exercises, then you need to be very individualized in your approach.
I really like that point, because I think one of my gripes is that people will often tell me, I've been given a sheet of A4 exercises and it's got the diagnosis on there. And it's just everybody with knee arthritis, whether that's maybe mild to more severe cases, is often given the same exercises. And I'm kind of like, oh, you know, tailor-made surely has to be the way forward, doesn't it, for that person? Would you, say if it was an arthritic knee, would you look at the other joints to see if the hip, do you go that far, what we might say, up the top of the body to the hip joint, or maybe to the ankle, or does it centre more on? Yes,
when we look at a patient, they may come up with a knee pain. But you got to keep in mind, often I tend to see patients for whom the pain has been ongoing for a long time. They may have already stopped doing a lot of activities. They may be fearful of it. It's a bit unknown. They don't necessarily understand what's happening. And as a result, you lose the ability across the ankle, the hip, the back. So yes, you integrate all these elements in your exercise. So we're not treating a knee, we're treating a person with goals, with desires, with wanted to go for a walk on the Peak District with their family. So that will involve working around the ankle, around the knee, around the hip, and you know, exploring this and what they want to achieve together.
Yeah, that's fantastic that you're looking at more of the body as a whole as well. I think that's fascinating, actually. That and 'cause, like you say, other areas are going to be affected if you've got a problem area, aren't they? I mean, this touches again. Ian has sent a question in. Thank you, Ian, for the question. Can I continue to run after being diagnosed with arthritis in my knee? I mean, this is difficult for you without looking at Ian, isn't it?
Exactly.
You want to assess.
Yeah, but in principle, again, the idea of running is a good idea, okay? But if Ian is in a flare-up, you know, and has really irritated his knee, you know, how do we modify the running so that
Yeah.
Ian can still enjoy his running, but without overloading the structures around the knee? As I said, it's not just about a cartilage wear and tear. This is not what it is. It's a whole joint ability to take load, and therefore, how can we pace Ian back to running normally, ride that maybe flare up, and being given a diagnosis doesn't necessarily mean, and I'm making maybe an assumption here, but you may not be symptomatic.
No.
Okay, as I said, you can have radiological evidence, X-ray evidence of very early wear and tear. I'm going to use the word very carefully here, of changes, but no symptoms, no pain, no swelling, nothing like that. Okay, so it's about, again, individualizing the approach with the aim to continue running, if anything, or maybe even progress running.
Brilliant. Now, you mentioned there, like an X-ray. Say an X-ray, does it tell the full story of a joint? Do we think, or an MRI? I mean, it's a really good guidance, isn't it? I'm guessing. But does it give us the full story on what that patient really can do or can't do?
Yeah, it's a good question, because I have a lot of patients who come in with an X-ray. Okay, and as I just said, if you put somebody in an X-ray machine or MRI, you will find something.
Yeah.
Okay, and as I said, arthritis is a whole joint issues. An X-ray is not going to show soft tissues. So it's a tool with others to get a clinical picture of your patient.
Yeah.
Okay, but it's to be taken within the context of the patient history, the story, what they've done, what they can't do, what they can do, and also maybe other medical condition they may have that may be, contributing more or less to their condition on the day they present. Okay, so you don't treat an X-ray. The X-ray is part of the picture.
Yes.
Okay.
Yeah.
But you treat a person.
Yeah.
Okay.
I mean, going back, I suppose, with Ian, with his running, and I hope you are still running, Ian, I suppose there's a bit of almost myth-busting we could talk about as well, isn't there? In the sense of, there's certainly been that culture that you don't exercise on a joint and you don't weight bear, and it used to be, get in a swimming pool, do you know, just go and swim if you can't do anything with these sort of things. But I think, as we've touched on, there's a lot of things, isn't there? My joints, I can't run on an arthritic knee. My joint's going to rapidly degenerate because I've just had this diagnosis of arthritis. Do you see a bit of this with your patients? And you have to break that sort of idea that's been placed into their head a little bit, which is myth, really, isn't it?
Yes, I do. I mean, this is a common feature, common denominator of the patient that I see. And it's understandable. But, all health professionals now have moved on from that. We know that, I'm going to use a slogan, lotion is motion.
Lotion is motion.
If the people listening to us remember one thing, is lotion is motion. Okay. Yes, I still have to educate patients that yes, there's a bit of changes, and you can see on an X-ray, on an MRI. But again, we go back that whole joint, aspect. We need to use the muscle to support the joints. So strengthening exercise will certainly be involved. Those structures help with the joint position sense. Yeah. So you train that. There's a bit of range of movement. You train and work a range of movement. There's a whole host of things that we can do to support people with arthritic diagnosis, even in a flare-up.
Yeah.
Okay. So that education, that myth busting is fundamental, particularly the word of wear and tear, is as a very negative connotation.
Yeah.
Okay.
Yes.
And it will create anxiety and concerns and fear. Yeah. And I understand why people come up with those concerns. But our job and my role as a physiotherapist is also to address those concerns. Okay. To the best knowledge of the evidence on the conditions.
Okay. It's fantastic. I mean, when you sort of wear and tear, I remember speaking to somebody once and they were saying, I'm going to stop my running now. I think this person was in their 30s or 40s because their father had arthritic knees, osteoarthritic knees, I should say, because then I'm going to protect my joints for later on in life. But you're stopping moving. you're stopping moving, you know. And that's another myth, isn't it? If I slow down a bit, then later on in life, my joints will be preserved.
Yeah, there's a degree of pacing, there's a degree of exposure,
Yeah.
okay? And we've all, you know, done a long run.
Yeah.
For example, when we haven't run for months and we do a whole run and then the next day our knees are hurting, our ankles are hurting,
Yeah.
okay? And then they do settle, okay?
Yeah.
But it's again, I go back to that resilience of the joints or resilience of the tissues to support
Yes.
this joint. And as we grow older, we see those changes as part of certainly aging aspect, okay, but there's a lot that can be done. I was recently watching the Stanic races over the Easter, and they have a category, age categories.
Yes.
So the winner ran in 32 minutes, but there was a 70 plus category, okay, somebody ran, you know, within 50 minutes. So it's a lack of correlation between, you know, the age and the state of our joints as well,
Yeah.
that we need to challenge.
Yeah.
Okay. Those people certainly exercise regularly, load their joint regularly, certainly pace themselves, and I've gone into a really good habit of maintaining good joint health.
Exactly.
Through
Actually,
activities.
It's a really interesting point, because, and this is one really for the audience that I think is really interesting, that when Pierre mentioned like the over 70 age group, don't be fooled into thinking, oh, that person's been running forever. Of course they're still able to run. I've worked with people that began marathon running in their 60s. They actually, rightly or wrongly, we could have another debate about that. So don't think when we're talking about age, yeah, but they must have been running all their life and they're conditioned to do it. Some of them have, of course, haven't they? But it's quite interesting that I've worked with people that have started lifting heavier weights in their 50s, 60s, and they've been okay.
Yeah, absolutely.
You know, because the body can take load if it's, I'm presuming, if it's the right amount of load and it's structured properly, Pierre.
Yeah, I think you touched on a very good point, and we go back to that individualized approach.
Yeah.
Okay, is where are you in your life, in your activities? You know, why? I mean, through history taking, discussion with patient, we get an understanding of what they may have done that may have irritating a joint.
Yes.
Okay, and we work with that, and we know that strengthening is important. We know that mobility of the joint is important. We know that, you know, joint position training, so specific exercise is important.
Yeah.
So yes, you need to do that, but you can't go immediately to
go run a marathon or something like that. That'd be a bit crazy, wouldn't it?
But it will be crazy for me as well.
Yeah.
It's unlikely it will be challenging for you as well.
Yeah, exactly.
Okay.
And funny enough, this has picked up Ian's message back. Strength and conditioning was very trendy a few years ago. I'd say it probably still is a bit trendy because there's worthwhileness to me, but you know. Do we still think strength is important for arthritic joints?
Yes. The short answer is yes, Ian. Yes, absolutely. As I said at the beginning, I keep coming back to the same thing, but we're talking about a whole joint, you know, condition. Let's call it a condition.
Yeah.
Where, yes, cartilage can be involved. But interestingly, cartilages, for example, are structures that have no blood supply and no nerve. Yet, the knee can be painful. So where is that pain coming from? Okay, and it's often the surrounding tissues. I'm not going to go into the whole pathophysiology of arthritis.
Fascinating. People go, oh, my cartilage is damaged, my cartilage is
Exactly.
hurting.
And there will be, yes, in very advanced arthritic condition where the cartilage will be damaged, there will be bone bruising, edema, and then you may look at a non-conservative approach. But strengthening, making sure the structures are resilient, and the word resilience is important, is there. There was an interesting podcast recently on BBC Stand with Dr. Chris and Zand on a colleague of mine, Dr. Kloskowska, who talked about HIPOA, hip osteoarthritis. And I really recommend listening to it as well, to our listeners.
Yeah.
Okay. Who talks exactly about that, the resilience of tissues. So strengthening is part and parcel of managing arthritis. Okay, it's where you start. How much do you do? You know, are you used to lifting weight and pushing weights, and where do we go from there? Or are you just starting? You know, so again, that very individualized approach, need an assessment first. Where are you in your journey to managing your arthritis?
Now, this is a question from me to you, really. You'll often hear of people talking of flare-ups. Again, it's like wear and tear. It's this language, isn't it? Do they exist in an osteoarthritic joint? Is there evidence for that? Because people, the bad weather or the wet weather, oh, my knee's terrible today. Is there evidence for that, Pierre? Is there any...
Arthritis has an inflammatory dimension. Okay, so you can have a bit of swelling, and there is, again, without going into the pathophysiology of arthritis, there's inflammatory element, which is why your knee will swell up. Okay, so you can flare up, but this can settle.
Yeah.
Okay, again, we're going back to the right loading. Did you do a bit too much? Okay,
yeah.
Too soon, too fast, too heavy, too quickly.
Yeah.
Okay, it's again, it would not occur to me to go to a gym and to do a squat with 150 kilos on a barbell, because I haven't done that. Okay, but I would certainly do squats with maybe 10, 12 kilos.
Yes.
It's again gradually loading, making sure those tissues have the ability to take the load you're putting demands on.
Yes.
And that's the key aspect. Yeah. So strength and conditioning, yes, is an important part and parcel of managing arthritis.
And do you know what I think is, I say myth, it's not so much a myth, it's maybe more something for clarification. Do you ever get a patient come in and, they've filled out a medical form pre the appointment and they've put, oh, I've got osteoarthritis. But then it turns out actually it's more of a rheumatoid arthritis. Now, what are the differences between the two, Pierre? Okay. I know it's a trick, but I think there may be people viewing today say, oh, I've got arthritis. And actually, they may have a different type. I mean...
That's a different, I think, debate and different podcast. But rheumatoid arthritis is an inflammatory, systemic, autoimmune condition where the immune system attacks itself. Yeah. Okay. Here we're talking about osteoarthritis, which is associated more with the load and the resilience of those tissues. Okay. So the rheumatoid arthritis is a different condition altogether. Interestingly, though, you still want in those conditions for the joint to be as resilient as they can be. So it will involve exercise. It will involve motion. It will involve a bit of strengthening. Okay, perfect. But there's a whole other management that needs to get involved with that.
I didn't mean to go off tangent, but I think sometimes it's one of these things, isn't it, where people, like if you say, as Pierre said, you'd want to come see Pierre at the clinic before embarking on lifting, as Pierre says, lots and lots of weight without knowing what you're doing. But again, for rheumatoid complaints, exercise very useful. I think we've got a question here, Baz. Thank you, Baz. My wife and I had to stop training because she was unwell. I have spinal arthritis. Will I be able to get back to training? I'm a bit worried. Rest means I'm on the scrap heap. Well, let's try and get Barry a bit more of a positive mindset, shall we, sir? Over to you.
Again,
Pierre.
Without knowing base, it's difficult to provide an answer, but arthritis will involve all joints. Yeah. Okay. So it can involve your knee. We're very familiar with knee and hip, but it can affect your spine. Yes. If you did an X-ray on me today, I tell you, Jay, you will find some arthritic joints in my spine. Okay. That's
very common as we're aging from a certain...
Absolutely. And I could go on and on about the imagery findings on arthritic joint in the spine, drier disc and that sort of things. Yes. And it's a feature of the general population who have no symptoms, no pain, no problems.
No pain. No. Okay.
So the answer again is yes. Again, you can retrain, you can work on spinal movement, you can develop strengthening around your glutes area, your legs to support the activities you want to do. Again, I go back to my motto around lotion is motion. Moving those joints, strengthening the abdominal muscle, maybe around the spine here, or your big spinal muscle could be something, but again, needs to be assessed. It needs to be individualized. It needs to be, and the whole person needs to be considered.
I'm so glad you mentioned the spine, because very easy for us just to think of knees and hips with arthritis, and people probably don't contemplate on the spine. And again, people want to be very protective of that spine, don't they? But actually, again, the right movement's probably going to help, isn't it?
And the spine is a very robust structure. It's got a lot of other tissues that support the joints. Okay, the muscle, the ligaments, without getting into too many details. So again, movement is important. Strengthening the muscles around are important. Being active is key. And that's the key message I think that needs to come out is keeping active. It's prevention as well. Okay, we keep going back into the need to be more and more and more active. Okay, we have an increase in diabetic patients and obesity for a variety of reasons. But a key element is remaining as active as you can be. Okay, and that will help supporting managing arthritic joints.
I'm sure some people watching today are thinking, this is the opposite of what I would have expected. I thought I would have been told that I need to take it easy and everything. So I'm glad we're doing some myth busting. A couple of questions from Joan. Thank you, Joan. I don't want to waste anyone's time. Is it really worth making an appointment with a professional? My hip hurts. The x-ray says I've got OA, so osteoarthritis, but it's not bad enough for an op. Should I wait? And it hurts. I should stop what I'm doing, question mark. My husband says I should rest because I'm old. Let's not cause a domestic, but Pierre, go on, tell me what you think.
I think we've answered that a lot, but just for Joan here. Yes, I would consult a professional to support you, to assess the hip, okay, and understand what you're struggling with, what you want to achieve, where also is your baseline functionally, what can you and can you not do. And then, as I said, we don't treat an x-ray. The x-ray is part of the picture, and it will, in all likelihood, show some changes to the joint. But those changes are not necessarily the cause of your symptoms. As I said, it's a whole joint issue. So therefore, building that resilience through activities, pacing, gradually progressing and building up the ability for those tissues to take the load is key.
So in answer to Joan's question, should I come and see yourself at the clinic? What would Joan expect? She walks in the room, because I think a lot of the time people are a little bit anxious if they've not seen a professional before.
Absolutely.
What are they going to do? Is it going to hurt me if they've been pulled around a bit in the past or something? So Joan walks in, obviously you've got the medical history. We've got a few minutes left just to put Joan's and maybe some other viewers' minds at ease. What would happen in that session with you?
So we will have an assessment, we'll have a long conversation. A lot of the information I need is from what the patient tells me. Okay, and then try to understand what Jones wants to do, what she's struggling with, and then we will have an objective evaluation. We'll look at the hip movement, some functional activities, just maybe reproducing a bit of the sort of pain or discomfort that Joan may feel, and then from there on is we agree together, working collaboratively, how we're going to start to manage that. I always put the patient at the center of the interaction. And
you're the support network for that patient, really,
I'm just another clog in the system to support that patient through education, understanding the condition, exercise provision, pacing, and then working towards goals.
And you're almost giving that patient that there's empowerment there, isn't there? Because people feel helpless, can't they, with these? And you're giving them, in essence, that power to take a bit of control back.
Absolutely. And the idea is not for the patient to keep coming back week in, week out. It's indeed providing that information, empowering the patient, and then we will have reviews based on what the patient wants to achieve. Okay, and the aim is to support the patient in the journey to managing this joint dysfunction. Let's call it joint dysfunction. Let's move away from arthritis.
Yes.
Although it is the right term, but I like it, joint dysfunction.
Yes, rather than centering on joint dysfunction. I like that. Very good indeed. Well, Pierre, we've just about finished, I think, for today. Went rather quick, didn't it? So that's all we've got time for today. I hope this has been helpful. And you'll join us for Osteoarthritis Part 2, where Pierre will go through some of the rehab processes with one of our clinic directors, Osteopath Stephen Bruce. Now, if you're already suffering with arthritis, remember that getting it looked at by one of the team can save you a lot of time and guesswork. Our next show will be on Tuesday the 14th of April, and our nutritional therapist, Anne Mather, will be demonstrating how glucose monitors work. What do they do? Should you have one if you're not diabetic? And can they help you lose weight? Join us for the answers. Until then, bye for now.